Hi, I'm Dr. Raheena, one of the mentor in Instutors. Okay, today I'll be taking you through it's a small, beautiful talk article. Okay, that is obstetric and perinatal outcome in women with endometriosis. Okay, this talk article is released in 2022 October. Okay, you might be, sir, being the endometriosis, that may be the very common topic you must be seeing in your clinic as well. That's a very important topic for Part 2 MRCOG exam as well. Okay, then coming to the topic, endometriosis is a growth of endometrial tissue outside the uterus, and it affects 10% of women, and out of it, 30% of women will be presenting with self-fertility. Okay. All right, the endometriosis as, yeah, 1 minute. Am I audible? Am I audible, Minhal?
Yes, ma'am.
It's close there. Okay. It's a yeah, we will be more common with the infertility patient with subfertility, isn't it? So the mechanism proposed to account for this subfertility are altered folliculogenesis resulting from the ovulatory dysfunction, poor oocyte quality, as well as a luteal phase defect, reduced fertilization, and abnormal embryogenesis. Okay, endometriosis has a negative impact on both assisted and natural conception. Okay, so this talk article, I'll be taking three headings. First one is pathophysiology. Second is adverse perinatal outcome. Third is the impact, that is implication of endometriosis in care of pregnancy. Coming to the first topic, that is pathophysiology of adverse obstetric outcome. That is the proposed theories are five that include secretory phase endometrial milieu changes.
Sorry to interrupt you, Dr. Raheena, but
Yeah,
we can't see the next slide.
okay, 1 minute. Is it okay now?
We're still on the
Hello?
first slide. Oh,
It's
sorry,
not
the
changing.
next one.
Can you see it now? Slide changing. Excuse me, can you see it now?
No, ma'am.
Okay, 1 minute. Let me check it. Slide share only the second slide.
Okay, ma'am, if there's any issue, so backend team can share the screen on your behalf. You just have to tell them slide, next slide.
Okay. I will do that.
Okay.
Yeah. Is it okay now? Hello?
Yes. Yes, ma'am.
Okay. Okay. Then first topic, that is pathophysiology of adverse obstetric outcome. The proposed mechanism is five. That first one is secretory phase endometrial milieu changes and the altered junction zone functionality, uterine hypercontractility, genotoxicity, and chronic inflammation. Okay, I'll be going through all these. First thing is the secretory phase endometrial changes that include due to the altered endometrial proliferation, altered glycosylation, progesterone resistance. Okay. So coming to the first thing, that is altered endometrial proliferation. As you all know, the endometrium has to go through some changes during the menstrual cycle. The first half is the proliferative phase and the second half is the secretory phase. Okay, proliferative phase is mainly due to the estrogenic effect. It's followed by the ovulation and the release of progesterones that result in the secretory phase, in which there is a changes in the endometrium we call desudalization that prepare the endometrium for implantation. Okay. In women during the proliferative phase, there is increase in the thickness of the endometrium. thickness of endometrium up to 10 millimeter. Okay, but what happens in the endometriosis? In endometriosis, the endometrial thickness is reduced in women, and that result in increased risk of implantation failure. Okay, the second thing is altered glycosylation. Okay, that means there are some glycoproteins present in the glycocalyx of the around the endometrial cell that plays as a receptors for the blastocyst. So the interaction between the blastocyst and the glycoproteins is very much essential for the implantation. Okay, so because of the altered glycosylation in the endometriosis, what happens? These glycoproteins are not formed, and this blastocyst interaction with the glycoprotein is not happening. That increases the that affects the interaction between the blastocyst and the endometrium, reducing the likelihood of implantation. The third is the progesterone resistance. So we already discussed progesterone is a very important hormone for preparing the endometrium for implantation. So what happens when the progesterones are released? These progesterones that causes the increases the immune mediators that help in the recruitment of the immune mediators that support the implantation, as well the progesterone hormone help in the preparation of the endometrium. There are two receptors or progesterone receptors in the endometrium, progesterone receptor A and B. Once this progesterone is attached to these receptors, there's release of paracrine factors that help in the endometrial changes, and also there's an upregulation of the enzyme 17 beta hydroxysteroid dehydrogenase 2 enzyme. Okay, so this 17 beta hydroxysteroid dehydrogenase enzyme that convert the estrogen, that is a potent estrogen, into a low potent estrogen, that is estrone. So that there is a reduction in the activity of estrogen, and the progesterone activity will be predominated. But in endometriosis, there is a down regulation of this enzyme, that is 17 beta hydroxysteroid dehydrogenase 2. Along with there is a decreased expression of progesterone receptor B. So these two causes a condition like progesterone resistance. So we discussed the pathophysiological change, that is secretory phase endometrial changes, and the second thing is increased uterine contractility, and third is genotoxicity. How this genotoxicity mechanism that affects the pregnancy. Okay, that means one of the genotoxic mechanism is the oxidative stress. Okay, the oxidative stress, that means usually there is a balance between the reactive oxygen species and the antioxidants. Okay, but in a woman with endometriosis, there's an increased reactive oxygen species that will cause the endothelial damage and endothelial dysfunction that consequent adverse obstetric sequelae like preeclamptic toxemia. Okay, then another genotoxic mechanisms involves are there's an increased iron content in the ovarian endometrioma. So what happens when the iron content in the ovarian endometrioma is more? That means that affects the newly forming oocytes, and thereby that decreases the quality of the oocyte, and that's why there is an increased incidence of miscarriages in women with endometriosis. The other proposed theory is altered junctional zone. This altered junctional zone causes a defective implantation and a defective placentation. Junctional zone is a subendothelial myometrium. That's a very distinctive part, which is a special that is architecturally and functionally distinct from the outer myometrium. Okay, and this plays a very important role in the placental bed formation. Okay, as you know, in adenomyosis, what happens? There's a thickening of this junctional zone. Okay, that can be seen in 3D ultrasound as well the MRI scanning. There is a thickening of this especially the posterior junctional zone. That this thickening of this layer has been associated with failure of implantation as well. As I told, this is the primary site of placental bed formation. Where there is a remodeling of arteries. Our spiral arteries are invaded by the trophoblasts, and the formation of large uteroplacental vessels is very important in the formation of healthy placenta. So
Madam,
the
still slides are not changing.
okay,
Yes, ma'am. Could you please tell me on which slide you are? So back in team
Still
can.
first slide, ma'am.
And also, whenever you move to the next slide, do ask
Yeah,
for
I will tell you. This is the
questions.
8th slide now. I'm 8th slide.
8th. Okay.
Okay.
You
Okay.
can just tell them to
Okay.
next.
I thought it's working now. I'm sorry. Okay. Okay. This is the 8th slide. Okay. Is it ready now? Is it ready? May I proceed?
Yes.
Yes, ma'am. It's also junction zone in defective presentation.
Yes, as it's altered junctional zone and defective implantation. Is it? Yeah. All right. So because of the abnormal junctional zone, it affects the placentation. As a consequence of these, there can be increased incidence of small for gestational age babies. There is more incidence of having this preeclamptic toxemia and preterm birth. Okay. The last pathophysiological mechanism is inflammation. The many studies have shown that there's an increased inflammatory mediators like cytokine, interleukin-6, interleukin-8, prostaglandins, and in the peritoneal fluid of women with endometriosis. And along with that, there is an estrogen synthase enzyme that is normally not seen in the endometrium, that is increased in women with endometriosis, that convert the androgen. That is, androgen is aromatized into estrogen by this enzyme. So, because of the increased estrogen, that also adversely affect the implantation. Next slide, please. So this is the nutshell regarding the pathophysiology and the adverse pregnancy outcome in endometriosis. So as we already explained that the first mechanism, that is secretory phase endometrial changes that include altered endometrial proliferation, altered glycosylation, progesterone resistance, and altered junctional zone. All these result in the pregnancy, the problems with implantation, defective implantation, that in turn result in the placenta previa, miscarriage, and the recurrent pregnancy loss in the pregnancy. Okay. So the other mechanisms like genotoxicity, increased inflammatory mediators, and altered junctional zone. These all makes like defective placentation, and this in turn result in small for gestation age babies, preeclampsia, preterm birth. Okay, am I clear so far? So the other risk associated with endometriosis is that we didn't explain till now, that is spontaneous hemoperitoneum in the pregnancy. Okay, this is a complication associated with endometriosis. It can happen during pregnancy. That is the bleeding inside the abdomen that occurs in 1 in 10,000 pregnancies, and 19 to 15.5.9 times it is maybe a result of endometriosis. This is coming to the pathophysiology of that. That is the one of the pathophysiology is the endometriotic deciduous implant involution. That is because of the progesterone resistance that make the vessels very fragile and can spontaneously bleed to produce spontaneous hemoperitoneum in pregnancy. Next slide, please. So then this completes the first session, that is the pathophysiology session. Then coming to the adverse perinatal outcome. Okay, this talk is based on summary of different studies that has been undergone regarding this topic. So these are the adverse perinatal outcomes seen in different studies. Okay, so the first thing is preeclampsia and gestational hypertension. Okay. Many studies have shown this association, but the overall association between the preeclamptic toxemia and endometriosis is not definitely established. This is a very important point to note. Okay. The second is placenta previa. Overall, endometriosis is associated with increased risk of placenta previa. But yeah, of course, we know that the placenta previa is, of course, the risk of placenta previa is increased in women having artificial reproductive technology for their pregnancy. But and also in endometriosis, the need for IVF pregnancy is more. But the data suggests that even in the spontaneous pregnancy, the endometriosis increases the risk of having placenta previa. The third one is metabolic complications. Okay, some of the studies shows that endometriosis as a identified is the woman with endometriosis, there is increased risk of having gestational diabetes mellitus and the this cholestasis of pregnancies, obstetric cholestasis of pregnancy. Okay, and also it is shown that gestational diabetes mellitus is more with spontaneous conception rather than an in IVF pregnancy. Okay, the last thing is the fetal and neonatal outcome. Definitely, the endometriosis affect the fetal and neonatal outcome. That is there's a increased risk of having preterm premature rupture of membrane, preterm birth, small for gestational age babies, and also the admission to a neonatal intensive care unit, stillbirth, and neonatal death is increased in a woman with endometriosis. So these are the some of the adverse obstetric outcome that is observed in the studies. You can see that these studies, that is a meta-analysis of the studies carried out between 2017 to 2021. There are 9 studies listed in which you can see that preterm birth is increased in almost all studies, and the small for gestational age babies is increased except in one study. Okay, yeah. And also the other thing, like, I'm sorry, it's 12th slide. And also the other outcomes like preeclamptic toxemia, cesarean delivery, postpartum hemorrhage, placenta previa, malpresentations, all are increased in some of the studies. But consistently, the preterm birth is increased in all studies. Okay. Okay, coming to the, please change the slide, 13th slide. Okay, one more complication that can happen because of endometriosis that already I explained about this spontaneous hemoperitoneum or hemorrhage in the pregnancy. It is characterized by the unprovoked intraperitoneal bleeding. It has an incidence rate of 1 in 10,000 pregnancies. Endometriosis associated with 19 to 55.9 cases of this. Okay, what's the pathophysiology of spontaneous hemoperitoneum in pregnancy that is associated with endometriosis? It may be due to endometriotic deserialized implant invasion can affect that affecting the appendix, terminal ileum, colon, that can cause tissue perforation and severe gastrointestinal bleeding, or urohemoperitoneum with urinary tract endometriosis. Then, and also under pathophysiology explained are involution of this desudalized endometriotic implant because of the progesterone resistance that can increase the vascular fragility and spontaneous peritoneal bleeding. Next slide. And the uterine rupture in the nulliparous woman, it can happen both during and after the delivery, maybe due to the uterine scar that is formed because of the previous surgeries like rectovaginal nodule excision, or due to the electrosurgical treatment in the stage 4 endometriosis, and also the chronic inflammation that is because of the endometriosis that make the tissues very friable and can cause spontaneous bleeding. Next slide. So this completes the adverse pregnancy, the obstetric outcome that is seen in different studies. Next, coming to the last session of our talk article, that is implication of endometriosis for care during pregnancy. That means what are the risk factors we are expecting in the during the antenatal, intrapartum, and the postpartum period, and how you will tackle what care you must given to these patients. Okay, so first thing, these women are divided in two, that is low risk endometriosis and high risk endometriosis. Okay, low risk endometriosis are the women, this woman does not need any special care in the pregnancy because we are not expecting any complication. That will go like a normal pregnancy and normal labor. But in women with high risk endometriosis, they need an additional antenatal and intrapartum care. Okay, so the woman who is coming in this group, high risk endometriosis group, that include adenomyosis, or the woman with conceived with assisted reproductive technique, or the woman who underwent the surgeries for the treatment of peritoneal endometriosis or a deep infiltrating endometriosis. Okay, am I clear so far? So these women need a care starting from the prenatal counseling, antenatal care, and the postnatal care. Next slide. So First of all, the preconception counseling for women. So actually, these women, high-risk endometriosis women, who will be having most of the women will have a long-standing infertility issues, and they will be desperate to have a successful pregnancy. Okay, so these women should be counseled prior to their treatment that there is what are the risks associated with it. Okay, the woman with endometriosis or adenomyosis conceiving spontaneously have an increased risk of having miscarriages, pregnancy-induced hypertension, preeclamptic toxemia, small for gestational age fetus, preterm delivery, cesarean section, neonatal admissions. Okay, so the woman with endometriosis conceived by ART, they have a 38% increased risk of having preterm delivery, 18% increased risk of having preeclamptic toxemia, 87% higher risk of having placental abruption, 29% higher risk of having neonatal admissions, 25% higher risk of having intrauterine death, and there is a twofold increase in the cesarean section deliveries and over threefold increase in the placenta previa. It's an important thing you should note this. You can come in part 2 exam. Okay. So next slide. Coming to the antenatal care. What are the antenatal special care that you should give to this patient that is high risk endometriosis group patients? That I already told is a high risk case. So they should have a consultant led care during their antenatal visit, okay? And also a multidisciplinary team approach is needed. It might include a senior obstetrician, neonatologist, endometriosis specialist, interventional radiologist, hematologist, colorectal surgeon, urologist. As necessary, they will be involved in the multidisciplinary team. Okay, and another very important thing is mental health and well-being. As already told, this woman with endometriosis maybe already gone through a lot of treatment, and they may have experiencing some mental health conditions like anxiety, depression, and which might deteriorate during pregnancy. So you have to give a special care for their mental health and the well-being. Okay, and and another thing is that the blood flow into the adenomatic lesion is abundant. And also the placental blood flow may be compromised because of the abnormal placentation, as we already discussed, because of many reasons. Okay. So these women will be more prone to pregnancy-induced hypertension and preeclamptic toxemia and small for gestational age babies. Okay. So in the woman with adenomyosis, you can expect a higher first and mid pregnancy mean uterine artery Doppler, and also in the first trimester there can be a lower pregnancy associated plasma protein A. Okay, so the adding a low dose aspirin during from the first trimester may be beneficial. Next slide. So, as we already told, there is an increased risk of having small for gestational age babies and PH. So, serial growth scans and close surveillance of blood pressure are also advisable for these patients. Okay. Then there is a higher risk of having preterm premature rupture of membrane in a pregnant woman with adenomyosis than a woman with endometriosis. And also they can have a chronic pelvic pain. So it can be already the patient may having a chronic pelvic pain because of endometriosis that can be exacerbated during the pregnancy, maybe due to the additions, bowel dysfunction, complications of endometriomas. That will be discussed in the next slide. The pressure of from the enlarging slides, especially in case of posterior deep infiltrating endometriosis and degeneration of adenomyoma. Okay. Degeneration of adenomyoma, even though it's a rare, the patient may present with a fever, abdominal pain, with increased inflammatory markers. The first thing we may be thinking about the acute appendicitis, like chorioamnionitis, adenomyosis, abscess. But this is another differential diagnosis when a patient comes with fever, abdominal pain, and raised inflammatory markers, even though it is rare. Okay, and the complication related to endometriomas. Next slide, please. The endometriomas can increase up to 20 centimeter during the pregnancy. So that can undergo torsion, cyst rupture. Rarely it can get infected and can result in peritonitis, and that may require surgery. Okay. Or these Because of this increased progesterone during pregnancy, there can be some extensive decidualization within the cyst that can become malignancy as well. Okay. So we will be monitoring these endometriomas every trimester using an ultrasound scanning. If it is not clear, we can use MRI without gadolinium. So even though if there is some complication related to cyst, we may have to do in surgery. Laparoscopy is preferred operative method up to 23 weeks of gestation. And with laparoscopy, even though after that, up to 34 weeks, we can use laparoscopy to remove if you have adequate expertise. Okay. And another complication that can happen is if there is an urethral involvement in endometriosis that can seen in 9 to 23% of cases. Okay, especially in the woman with ovarian endometriomas or a deep infiltrating endometriotic implants. So in such women, 9 to 16% of cases may have urinary symptoms. Rarely patient can have problems with ureteric stenosis, hydroureter, hydronephrosis, and renal damage. Next slide, please. So that is the antepartum problems that we can face and what are the care we needed to give the patient during the antenatal period. Then coming to the intrapartum care and mode of delivery. Okay, so as we already tell, as this is already explained, as this is an high-risk pregnancy, it need a consultant-led service for during the delivery. As there can be some many complications we expected during delivery. Okay, so especially the endometriosis, the anatomy may be very much distorted because of the pelvic adhesions, and if at all there's increased risk of cesarean section, so this should be taken care of. So the patients need a constant-led service, and as well the increased risk of malpresentation, especially the breech presentation, is with adenomyosis and other endometriosis as well. So, and also there is a higher risk of failed induction and labor dysocias. And the other thing is you should be aware that there can be prior uterine surgeries that may affect the myometrium. Okay, especially some nodules, some increased diathermy usage can make the uterus very thin and can result in uterine rupture before or during delivery. And we should be aware that the baby may need intensive care, unit care, and there is risk of having stillbirth and neonatal death. So during when the patient is in active labor, we will have an intravenous access as early, and also we will be sending a full blood count. We'll group and save the blood as there is an increase in risk of placenta abruption and antepartum postpartum hemorrhage. Okay. And also, as there is a risk of fetal distress, we will be monitoring the baby continuously with CTG. Yes, most of the women will achieve a vaginal delivery, but when that woman the patient should be counseled regarding the increased risk of having perineal injuries, especially the 3rd and 4th degree tears in women with rectovaginal endometriosis. Okay. And the large endometriomas can have a negative impact on the vaginal delivery and have been, sometimes it can cause obstructed labor as well. As already explained, there is increased risk of breech presentation. Okay, as we told, there is an increased risk of cesarean delivery in women with endometriosis. Compare cesarean delivery rates with the disease subtypes, okay, or the frequency, that is 42.9% with rectovaginal endometriosis, 40.4% in women with ovarian endometriomas and peritoneal implants, 31.8% with peritoneal endometriosis, and 20.5% with ovarian endometriosis. There is also an increased risk of cesarean delivery in women with deep infiltrating endometriosis, whether it's anterior or posterior compartment, regardless of previous surgery is present or not. So all these endometriosis, especially that is affecting the colorectum or the this bladder, everything. If already there can be obliterating these spaces, so there should be a senior consultant doing the surgery, especially the patient is having a stage 4 endometriosis or the patient is having a previous history of surgeries. So there can be more chance of adhesions and injury to the adjacent organ. So it has to be undertaken by a senior obstetrician. And also, if there is there is any chance, like we can do a opportunistic surgical treatment, can be considered the large ovarian endometriomas at the time of planned cesarean section to avoid pain and torsion during the postnatal period. Next slide. It is the last session, that is a postpartum care that should for the patient with endometriosis, that it need a active management of third stage of labor that helps to reduce the postpartum hemorrhage, anemia, and need for blood transfusion. Okay, and also the pregnancy that creates a pseudo-menopausal state and that may causing a remission of endometriosis. Once the delivery is over, they can have remissions. So the patient should be aware that there can be recurrence in the puerperium. And also the spontaneous hemorrhage, the hemorrhage or hemoperitoneum in pregnancy can be associated, can be, there are reports, they can occur up to day 9 postpartum period. So hypotensive after delivery, that that warrants an investigation. We have to rule out this spontaneous hemoperitoneum in pregnancy. So, in nutshell, I am going to summarize what we have learned, discussed today. The last slide, that is a endometriosis, endometriosis in pregnancy, how you will manage, what are the complications we are expecting during the pregnancy and how to manage it. Okay, so first of all, it is divided into two groups, low risk endometriosis and high risk endometriosis. Okay, we already discussed high risk endometriosis is a woman with adenomyosis. Patient received any treatment like artificial reproductive techniques and the or the woman and the woman with previous surgeries for peritoneal disease or deep infiltrating endometriosis. So these women needed multidisciplinary team approach that includes senior obstetrician, endometriosis specialist, urologist, colorectal surgeon, interventional radiologist, hematologist, that as necessary. Okay. The care start with preconceptual counseling. We should counsel the patient with having an increased risk of having miscarriage, preterm birth, pregnancy-induced hypertension, preeclamptic toxemia, placenta previa, cesarean section, postpartum hemorrhage, neonatal admission should be explained to the patient. And also we should explain the patient of increased risk of having perineal injuries, third and fourth degree tears at delivery, especially if the patient is having rectovaginal endometriosis, and also increased risk of having these increasing the size of endometriomas and rupture, abscess formation or that may mimic the as malignancy. And coming to the antenatal care should be done in consensus-led unit, and there should be an increased blood pressure monitoring. Consider aspirin in early pregnancy to reduce the risk of having PIH and preeclamptic toxemia. And also the endometrioma surveillance each trimester and rule out malpresentation because that is common with endometriosis. And there are regular whole growth scan to rule out small for gestational age babies and rule out placenta previa and accreta. And coming to the intrapartum care, we have to secure an IV access once the patient is established labor, send a full blood count group and save in established labor as there is increased risk of postpartum hemorrhage. Continuous CTG monitoring in labor. There is also, they should be aware that increased risk of having failed induction and obstructed labor. So they may need cesarean sessions. Early recourse to cesarean section may be considered if there is an unexplained abdominal pain, hypotension, hematuria, since there is a risk of having spontaneous hemoperitoneum in pregnancy. And senior obstetrician is very much needed at the cesarean section, especially in the woman with a previous surgically treated endometriomas. And the postpartum care, yeah, there is the risk of having postpartum hemorrhage, so you have to do a manual removal of placenta. You have to do an active management of third stage of labor. We may need a manual removal of placenta in these cases, and risk of neonatal admission to the neonatal NICUs, ICU may be needed post-delivery. And the risk of having postnatal torsion with large ovarian endometriomas can also be present. So we should be aware of all those things. So this complete our session on this adverse pregnancy. Yeah. this talk article. Okay, so do you have any questions? I know it's a non-interactive session. It will be very boring, but it's a very simple topic. You can go through these slides. It is available. So this is a very simple topic of obstetric and perinatal outcome in pregnancy in women with endometriosis. So if you have any questions, you can ask in chat box. And okay, any questions? And we are, yeah. Is it audible? Is it audible?
Hi, good morning.
Yeah, good morning.
I would like to find out in terms of the most common complication in terms of the fetus, would it be preterm labor, preterm delivery?
Yes, or yeah, I will show
That
you
would
that.
be, if you look in terms of the most common for the fetus, and then in terms of the most common from maternal complication, what would that be?
Yeah, yeah, the studies have shown that most of almost all studies have shown preterm delivery as the complication. So it is the most common complications preterm delivery, of course. It's followed by small for gestational age babies. Is it clear?
Okay, thank you. And in terms of the maternal, the most common maternal complication would be what?
Yeah. The studies, yeah, of course, that include these plus postpartum hemorrhage in most of the study. Yeah, in the 9 studies listed, the 5 studies showing postpartum hemorrhage. Yeah, of course, placenta previa that occurred in 4 studies among the 9 studies listed. So these are the two most common complication: placenta previa and postpartum hemorrhage.
Okay, thank you.
Thank you. Any
Okay,
questions?
yeah, we also have a few more questions in the chat box. Would you please check those, or you want me to read them out?
Yeah, let me check it. Can you read for me? There's some confusions in it.
Sure. So there's a question. Can we need to do a laparoscopy for pregnant lady with endometriosis?
Yeah, of course. Laparoscopy may be needed in pregnant ladies in endometriosis if there is something like any torsion or any signs of rupture, they may need. It is preferred. Laparoscopy is preferred up to 23 weeks. After that, it can be done up to 34 weeks if expertise are available, but it is preferred up to 23 weeks. Is it clear? Am I making sense? Am I answered your question?
Yes, ma'am.
Okay.
So there's one more question. It's from Dr. Shabana. It's SGA or PTL. You're asking about it.
Most common is preterm delivery. I know this is actually there is some problem with the these technical difficulties. I can it will be always better if I can see everyone and take a session. I know it will be very boring because I can't see anyone. There is some problem with my computer. Okay, any questions? Any more questions?
Okay, Dr. Raheena, I think we don't have any questions, so we should call it out.
Yeah, thank you very much for patient listening. And first of all, I apologize for some technical difficulty that I faced during the session. Yeah, it's nice to take a session. And yeah, of course, we are I'm representing the Med Instutors, and we are here to support you in any ways that you want. And as well, we will be coming with more free videos for you. And we can arrange some interactive sessions as well. Please follow us in social medias. Okay.
We got one more question.
What to do for recurrent endometriosis after laparoscopy twice seeking pregnancy? Mm, yeah. Uh, most of them, especially these endometriosis, we may have to go for in vitro fertilization. The artificial reproductive technique may have to, we have to refer the patient to the fertility specialist. And once the surgery is over, it is better to have the pregnancy as early as possible before the recurrence happens. Okay. I think that's your question. Can you open the mic and ask if at all it's not clear? Always prefer to do a surgery after completing the family. Always a definitely surgery is done only after completing the family. So whenever we do a surgery, try to refer the patient immediately to a fertility specialist, and the pregnancy has to be planned as early as possible before recurrence. We know that endometriosis definitely that will recur. Recurrence is very common. So we have to plan the pregnancy as early as possible after the first surgery. And surgery is done, the definitive surgery is always done after completing the family. Yeah, one more thing is that for part two exams, the advice I can give you that you should be very thorough with the green top guidelines and NICE guidelines. Yeah, of course, talk article is also important, but it's only after the taking all the green top guidelines and these NICE guidelines has to be very thorough with, and after that you can go through this type of slide, only this type of slides for talk article. There's only few points that you have to be noted in this session. Okay, so just take down that point, especially the tables. Okay, always tables and charts are very important. So whenever you study, even though it's a green top guidelines, even though it's a NICE guidance, please make note of these tables and charts, and you have to revise this as much as possible. So you can place it in your table or study, some folders should be there so that you can see it every day, or especially the important charts. Example, the postmenopausal uh, treatment for postmenopausal ovarian cysts. That's a very important chart. That should be, if you see is every day. Yes, the other thing is venous thromboembolism, the risk assessment. That we may forget it. Okay, even though we have gone through this multiple times. So you have to see it every day so that that will be very thorough in your mind. And also it is very important that if you are very thorough with the with the green top and the NICE guidelines, it will also help for your part 3 exams as well. So that's all. Thank you for patient listening. Any questions?
If you guys have any question, you may write down in the chat box, or we are going to. Okay, so yeah, we also have another question from Dr. Khadija.
Yeah, of printouts. Printouts, that's your preference actually. If you need it, it's okay. If you are more in fond of reading the things in by the papers, yeah, of course. Or you can make notes on GTG and NICE guidelines. That's actually, it's very important to make the notes, because next time you may not be able to read all these GTG and NICE guidelines, and you can make notes, and every point you should, you will say no, read between the lines. No, you should read it very thoroughly and make a note of it. Okay, and so that you can repeat the notes every time. But printouts, if you are very comfortable with printouts, reading printouts and marking it, yes, you can do that. Otherwise, just read that and make your own notes and write it and repeat it, and or you can revise it as much as possible, because these TG guidelines know that are actually is very simple. If you are going through it's repeatedly, that will become very easy for you, so you can answer every question in part 2 exam. So if you have the GTJ nice guidelines very, you know this very thoroughly, it will be very easily you can clear it in first go. Okay, so yeah, if you are comfortable with these paper works, it's okay. It will be nice to have printouts of GTJ nice guidelines, or you can have a notes. You can write down the notes, important points, and you can revise that. Any other questions? The most important thing is consistency. Okay, sometimes we'll be very much interested in studying, and we will start studying. The next day we will be engaged in our duties and all things, we will just leave it. So the consistency is the most important thing. You have to do it at least 1 hour every day, because the consistency is the most important thing, rather than doing it for 1 week. You will be okay, second week you will be out of the studies. So be consistent with your studies and try to clear the exam in first go. Thank you everyone. I think we can wind up.
Yes, and thank you so much, Dr. Raheena, for the
Thank
wonderful
you very
session.
much. I think I have faced a lot of technical difficulty. It's okay.
We will,
Sorry for that.
it's fine. We will be, we will take the responsibility.